Hello, everybody. My name is Brittany Kim. I'm a physical therapist at Re+active, and I'm the education coordinator there as well. I do a lot of behind-the-scenes work, a lot of mentoring at Re+active, and mentoring in Brain Bites. I'm going to bring in Brittany Charle, so you get two Brittnys today instead of just one. I'm going to invite her, and her Instagram handle is a sense of today, and to discuss 3PD, which is such an interesting topic in diagnosis. There's Brittany. Okay. Hi, Brittany.
Yes, the Brittany attack.
It is the Brittany attack. So today we thought we'd start with talking about what is 3PD and also kind of how we break it down a little bit more. And then we also got a lot of questions from you guys, so we wanted to spend some time answering those questions. And if you guys are here joining us live, then you can ask questions as we go, and we'll try to keep track as best we can. So I don't know, Brittany, do you want to start with the diagnostic criteria for PPD or PPPD, I guess?
Yes. Yeah, so for people who don't know what PPPD is or 3PD, it stands for persistent postural perceptual dizziness, and it is a chronic functional vestibular disorder. And so we have here, yeah, Brittany has pulled up the diagnostic criteria because it's really important to be able to differentiate between different disorders. So as far as 3PD, what people experience would be non-spinning dizziness. So rather than vertigo where you see things moving, you have more of an internal sensation that you're moving inside, or you might be rocking, bobbing, you might feel foggy, lightheaded, have unfocused vision. And these symptoms typically are pretty persistent and they are prolonged. They last for hours. And maybe throughout the day they wax and wane a little bit, but they're present most days. And some people say that it's even 24/7 for them. And these symptoms are lasting for at least 3 months. So it's been going on for a long time. And oftentimes with the vestibular testing, a lot of the results are normal. So you might get tested and a doctor might tell you, well, we're not seeing anything wrong, but you're actually sensitive to the tests. So they might not feel good, the test, but then the doctor might say, oh, well, you don't actually have anything wrong per se. So that happens often. And then a lot of times people can note a distinct triggering event that happened before all these symptoms started to occur. And a lot of kind of provoking or triggering factors can be if you're seeing some sort of complex visual motion. So a lot of people will say that it gets worse when they're at the grocery store, for example, or active or passive head motion, which can occur while you're walking, or when you're sitting in a car, sitting in something that's moving, or on an escalator or an elevator. And then it's usually most severe when you're in upright position. So when you're either walking or standing versus you feel better when you're laying down. And then these symptoms are typically quite debilitating. It's really affecting your daily life. So that would be the diagnostic criteria for 3PD.
Very cool. And then I know that you created this beautiful pie chart. I thought we should go over it because at Re+active we love to use a lot of pie charts to break down complex problems. And today some of the questions that we had, we thought it would be really helpful to start with this, so then that way we can refer back to it while we're answering some of the questions. So I'm going to pull up the pie chart real quick. And then I don't know, Brittany, if you want to also review kind of like how you use it when you are encountering someone who has 3PD. So I'm going to show you guys what the pie chart looks like.
Perfect. Yes, so we love pies at Re+active. Basically, the purpose of our pie charts are to make sure that we get the full picture with somebody and that we're not just so narrow focused that we end up missing something that's really important with the person. So 3PD can be quite complex in that there are multiple pieces of the pie. So we have there, I don't know, it's a little blurry on my end. So if it's the same for you, I'll just kind of read those categories out loud. So you have you have psychosocial component, and then you have a lifestyle component, autonomic, predisposing or perpetuating factors, and then you have the different sensitivities of your sensory system, and you have sensory weighting. And so all those different pieces can be affecting how you're feeling, and it's important for us to know which pieces contribute more than others so that we can kind of focus your treatment. And you might imagine that you need to work with possibly more than one healthcare provider to address all of these things at the same time.
Awesome. I just also like that it's pink, which I think is pretty fun for 3PD. So yeah, I think we should get into some questions, and then and we're going to do kind of like a back and forth on some of the questions that we had given to us from you guys. Can I ask you a question first, Brittany? Because I'm actually really curious about what your thoughts are. Someone had asked about post-concussion, and you're our post-concussion expert at Re+active, and you do all of our concussion intensives, and I feel like it gets really confusing when someone has a concussion and has dizziness, because it could be even more multifactorial in that kind of situation. So how do you know like the difference between 3PD and also PCS vestibular systems that have just persisted over the last few years? So how do you break that down, or what's the difference in your mind?
Yeah, I really do use the diagnostic criteria of 3PD as a checklist. So I will go through and I'm like, okay, if you're having dizziness and it's not spinning vertigo, then I'm like, okay, that checks off. That's meeting kind of the 3PD, and if it's been persisting for 3 months. But then really the triggers tend to help me know. So if it's really the position changes, where when you're more upright, when you're standing and walking, that your symptoms are worse. I find that is usually when I'm like, oh no, it's still related to concussion. These are post-concussive symptoms that have just been super persistent. And what we'll find too is that it's really like that complex visual motion that's triggering. So when I find that people post-concussion have those same symptoms but with other triggers, then that's when I'm more thinking that it's still from the concussion. But there is an incidence of around 15 to 20% of people post-concussion that do end up developing the 3PD. So you can have both, which sounds, I'm sure, confusing to some. But yeah, that can totally happen.
Yeah.
So yeah, I have a question for you, Brittany.
Okay.
Yeah, so just like going off of different diagnoses that might come before 3PD, another great question that somebody had was, do you see a correlation between 3PD and POTS?
Yeah, so I did a little bit more research on this to see, like, is there some sort of incidence with POTS and 3PD? And I wasn't able to find a certain number of, oh, this many people have POTS as some sort of precipitating event or, factor. But I think it's the one of Dr. Staub's articles, he mentions it's for the diagnostic criteria. And it's in 2017. There's a whole section in that article, and I can have the reference posted. It's a free access article, which is really nice. And in the article, he talks about briefly dysautonomia and how there can be autonomic sources of dizziness, which is really interesting, right? And then also that it can be one of the triggering events that can occur prior to someone then developing 3PD also. So it's something to consider. And I would say dizziness, I think, does feel very confusing a lot of the time. But with POTS, the deciding factor, kind of like you were mentioning, going back to the diagnostic criteria for 3PD, with POTS, there's clear diagnostic criteria that there's a change in the heart rate of 30 beats per minute or more increase with a change in position into more of an upright position. So if you're seeing a change in vitals, there may be some sort of dysautonomia present. And in the article, he also mentioned that 3PD doesn't typically present with changes in vitals. So if someone does have a change in vitals, then there is probably, that's not what we would expect. I want to make sure we clarify that. Then we're not maybe thinking, that 3PD might be there, but it could also still be a triggering factor into it. So yeah, I think it would just be nice to be able to rule out at least dysautonomia, if that makes sense.
Yeah, that's good. And even just going off of that too, someone else was wondering, should there be some sort of like proactive education as part of POTS treatment? Because like you're saying, maybe that's a precursor. And so would that help potentially avoid some sort of like fear messages when treating somebody with POTS that maybe ends up having some not completely unrelated, but some like dizziness or 3PD later?
Yeah, I mean, I think it's really important to provide that education about, so if this is someone who's coming in with POTS, that it can be helped with exercise and lifestyle modifications like increasing fluid intake or compression or whatever that might be with your particular dysautonomia, but particularly with POTS, those are the big things that are important. And that it is easy to stop moving because with POTS, being in an upright position is either creating brain fog or dizziness or headaches or other kinds of things. And so it is important to do exercise, but that we can grade it, right? And do that in a way to help build their tolerance and reset their cardiovascular system and autonomic nervous system.
Yeah.
And then I would say, like, if they are presenting with 3PD-like symptoms, that I think probably starting, and you can chime in on this, Brittany, too, but I think starting with addressing the POTS would be a really nice place because it's a trigger that feeds into their 3PD cycle potentially. And then if that's kind of all over the place and dysregulated, I think it'd be really hard to do the other stuff without trying to get that going first. Mm-hmm.
Right. And then like you're saying, they're separate anyways. So it's not like treating the 3PD would necessarily treat the POTS.
Yeah.
So like you would need to treat the POTS, which then kind of answers somebody else's question who was asking if there tend to be blood pressure fluctuations with 3PD, or is it typically a result of another diagnosis? And so that's kind of what you're saying there. It's like treat the POTS first, and then that can help improve your progress with that person with 3PD if they also had that.
And I would say the overlap of the Venn diagram there might even be doing some sort of autonomic nervous system calming activities could help with both conditions. And if you can regulate your autonomic nervous system better, then that can help with the POTS and that can help also with the 3PD. So you might get a 2-for-1 out of that situation if you're trying to be a little more efficient with your care.
Yeah, exactly. I find too, and please chime in too if this happens with you, where the autonomic regulation is often a missing piece. Mm-hmm. You see people, usually we're not the first people that they've seen before for their condition. Yeah. And often I find that I'm identifying somebody's symptoms as autonomic, and they're like, what is that? And having to address that makes a huge difference.
Yeah, definitely. And I know we had another question because I feel like right now we're on this differential diagnosis path, and we had this question about autoimmune conditions and feeding into potentially 3PD or having that at the same time, both together. And what I was going to say about that, I tried to do also another literature review to understand kind of the contributing factors. We do know that autoimmune conditions do feed into functional neurological disorders, which is 3PD falls under the umbrella of functional neurological disorders. And functional neurological disorders are just basically the brain is rewiring, and that creates some sort of change in the nervous system function, whatever that may be. And in 3PD, it's dizziness. And autoimmune, there are actually incidences of autoimmune dizziness, which is really interesting. And I did not know until I researched this. It's like a type of vertigo that can happen with autoimmune changes. Also, I've seen personally with other functional neurological disorders that when the autoimmune condition is a little out of control or not being well managed, that that is a trigger for those symptoms. And so I think it's important to have a really good medical team. And I know, Brittany, you talked about, you know, it might not be just a physical therapist on your team, but in this case, if you have something like that, that you need to have a really good rheumatologist and, you know, probably a really great primary care physician who can help coordinate some of your care. And then with autoimmune conditions, in particular, at least with some of the literature that I saw for vestibular conditions, they were suggesting, this is just true for any rheumatic condition, is steroids tends to be a first line of treatment. And it'd be interesting to see, like, if you address that condition, does your 3PD maybe change? Because that's a trigger that's gone, is those changes of the immune system on the nervous system. But then you also have to consider lifestyle and like diet and exercise and stress management and, you know, your mental health and all of those things together. So again, it's multifactorial, and to take care of yourself, you know, requires, I think, maintenance in all those areas and having a really good supportive team for sure.
Yeah, that's great. No, and I guess that goes back to our pie chart where there's that piece, the predisposing factors. So a lot of times, right, 3PD, it's this functional neurologic disorder, and it's often on top of something else, right? And so if the thing that's underneath it for you is your autoimmune disorder, that needs to be managed first to even be able to address that second layer, which would be the 3PD.
Yeah, and Amy's mentioning also the effect of high dose steroids on the body. Yeah, this is where it gets even more complex, right? So I think having a good medical team on board that understands your body and also what's happening in your whole system is really important, because if certain medications you're taking are creating problems in other areas, it's a dynamic process that you just need a good team to help you with. And actually, speaking of team, we had another question about how to work with ENTs and MDs and neurologists who might not know what 3PD is. And I was kind of curious about how you handle the situation, Brittany, because I just feel like I think it's really hard sometimes, that communication piece.
Right, it is, because honestly, 3PD is a relatively new diagnosis. So there are a few precursors to 3PD, and so some doctors just might not know of the new term. So even this diagnostic criteria was just published in 2017. We've spoken to doctors ourselves about 3PD, and they've said, wait, what is 3PD? And when we've mentioned the precursors, they're like, oh, that, you know, and that makes more sense. And so those diagnoses that you might want to be aware of in order to mention to your doctor would be phobic postural vertigo. That was a precursor. Space motion dizziness is another one. Chronic subjective dizziness, and there's a fourth one, visual vertigo. So those might be terms that you might provide to your doctor that makes them go, oh, okay, that's what we're treating. And I think also just not being afraid to ask the doctor, you know, do you have experience with this type of condition? Or, you know, can you refer me to someone who does? Or if that person doesn't know but is willing to dive into the literature, that's a great trait that you want to look for in a doctor, somebody who's curious and is willing to investigate. That could take you really far too, even if they hadn't originally heard of this latest term.
And then they become the local expert. That's like how it starts, right?
Exactly.
Is with a patient being in their willingness to learn. So, yeah. I'm trying to look through the rest of our questions too. I think, I don't know, Brittany, is that it? Those are like the big questions, I think. Is there anything else you can think of?
Oh yeah, you know what? I think our last one might have been, what are some ways that a patient can overcome the challenge of maintenance?
Okay, yeah.
Yeah, so I think we were, so Janine Holmberg
Mm.
is amazing and has kind of provided just like what she calls a three-pronged approach to treatment with 3PD. And so that includes vestibular rehabilitation, and then psychology, specifically. I mean, new literature is coming out literally every day. Originally, I believe that cognitive behavioral therapy was the main avenue, but we're also finding now that acceptance and commitment therapy is also useful. So that's nice to have more than one option. And then the third thing would actually be medications, in particular, low dose antidepressants. And research has found that those three really, really increase the rate of success that people have in treating. And yeah, actually, I'm seeing a comment right now about asking, did we talk about the role of CBT on 3PD? I tuned in late. Sorry, no, you tuned in right on time.
Yeah, basically, Gail.
Yeah. So yeah, I mean, super cool. CBT is definitely utilized, and then like we were just saying, ACT, and it's really just helping to identify certain thought processes, certain maybe maladaptive behaviors that might be occurring, and how a shift in mindset can really help kind of disrupt those negative feedback loops in order to promote recovery. So I've found that the people that I've treated, when they're just seeing me as a physical therapist for the vestibular rehab, it tends to not be enough. You tend to want to have at least 2 out of those 3 treatments. And definitely, I do find that the antidepressants help, and the way that they do is to just open up the neural pathways so that your threat response is actually lowered, so that you aren't triggered as much as you're trying to heal. And those doses are quite low. They're 20 to 50% the dosage of somebody who has clinical depression. So I know people worry about that. And then basically, once you're at a point where your symptoms are gone or you're managing them, you would then start to taper off on the medication. And the taper is quite slow. It can be up to a whole year just to avoid any sort of withdrawal symptoms. So having a great psychiatrist can be key with that management.
And Brittany, it looks like Gail has a patient who has 3PD and possibly, or it looks like there's like a differential here, maldebarkment. She's high functioning, but she feels crappy with everything. And I guess Gail is considering potentially referring to CBT for her to have CBT. And I'm not sure, I'm totally assuming here. But have you had any patients who've undergone CBT as a treatment for 3PD? And kind of like, I mean, I know of the concepts and the principles behind CBT, and have seen it used in my patients who have chronic pain.
Yeah, no, I have. Yeah, I have seen people with 3PD who do receive CBT, and I do think that it's complementary. It usually doesn't need to be for very long. So it can be more of a short-term thing, short-term meaning like 2 months sort of time frame. And then basically too, what you're doing with all the therapies, as the person's learning to self-regulate, you would start to taper. So the same concept applies to physical therapy, where you might start with visits once or twice a week, but you really want to get to a point where you could potentially see that patient for, let's say, 12 visits over a period of 6 months. So there should, really be a point where the person's learning to kind of self-regulate and you're tapering. And as that person is introducing things back into their life again, that you're then there to help guide them as they problem solve through any new triggers that they didn't know of because they just weren't exposing themselves.
Yeah, definitely. Well, Brittany, thank you so much for being here with me, the other Brittany. We have four Brittnys. I just want you to know that I reacted. And I just also wanted to let you know, I saw a comment here about if we have the Holmberg article. So I think what we'll do is for our post, we'll have the citations for the articles. Some of the articles that we mentioned today are free access. I don't know if any of Janine's articles are. I'd have to check and see, but we'll have the citations there so you could look them up on Google Scholar. And then also, if you want, you can join our newsletter. And in that newsletter, we always have links to the articles. We have the videos posted there, except for I don't know if we do the Instagram lives and put them in the email, but I know for sure that we do for like our Facebook lives. So please sign up for our newsletter at reactiveeducation.com. So then that way you can stay up to date with the latest research and things that we're learning all together as a group. And then finally, on Friday, if you want to join Mike Studer and I, we're going to be talking about all things neuroplasticity at 12:30. We're going to be doing a Facebook Live together, and I'm really excited to see Mike. He's going to be at, I think it's the Rehab Summit in Las Vegas, and so he's going to talk about the courses he's teaching, and I also am going to ask some questions about just what makes him tick, because he's just such a fascinating human. So yeah, but thanks again everybody for joining, and thank you Brittany also. I hope you have a good night.
Bye.
Bye.